Good evening, everyone. I'm Keiichi Ozono, Osaka University. I'm very happy to present our experience with hyposphagia here in Taiwan. I hope my talk today will help you to see patients with hyposphagia. My talk today is about accurate diagnosis in patients with hyposphagia. This is my disclosures today. So as mentioned, Professor Lin, I'm invited by Alexion Pharmaceuticals, and some slides provided by Alexion Pharmaceuticals. Here is the outline of my talk today. Hyposphagia and history, definition, clinical subgroups, and role of alkaline phosphatase in mineralization. And then I talk about the clinical manifestation, skeletal and extraskeletal. And the most important part of my talk today is the diagnosis criteria or some tips. So hyposphagia, HPP, as you know, is one of skeletal dysplasias caused by mutation in LPL gene. HPP is diverse in phenotype and classified based on the age of onset and clinical features. HPP is usually inherited in an autosomal recessive manner, but autosomal dominant inheritance is also recognized. To date, more than 330 mutations were reported and are registered here. Precise prevalence is not provided, but around 100,000 births. So it means maybe 1 or 2 baby of HPP in Taiwan is born. And the bone target enzyme replacement therapy is available in Japan, US, UK, German, Canada, Australia. But in Taiwan, it's not improved. So I will focus on the diagnosis of HPP. Hyposphagia, HPP, was firstly reported by Dr. Lassman, a Canadian pediatrician, in 1948. The first report beautifully described the features of HPP, like a 3-week-old boy admitted with history of failure to slide, seizures and spontaneous crying, and born at full term, breastfed without difficulty. X-ray shows severe rickets and fractures. Serum LP activity was low, and normal to elevated serum calcium and phosphate levels. And patient died at 2 months of age, secondary to seizures. Low LP activity in bone and other tissues documented at autopsy. So they are the characteristic to HPP. HPP is, in 1980s, HPP was proved to be caused by the loss of function mutations at LPL gene, coding for TNSLP. TNSLP forms a homodimer or tetramer to exhibit enzymatic activity. And there are several important domains or sites, such as calcium site, active site, homodimer interface, calcium site, and the crown domain. And the amino acid change in these sites goes down to the enzymatic activity. Based on the onset of age and the clinical features, HPP is now classified into 6 subtypes described here. The most severe one is the perinatal lethal form, which is apparent in fetus or neonatal period, and the perinatal lethal form is associated with severe mineralization defect and respiratory failure and convulsion. In contrast, at the same time, in fetus or neonate, there is a perinatal non-lethal form, which is associated bone deformity, but no respiratory failure, and the prognosis better. And the infantile form is obvious in infant and associated with failure to thrive, hypercalcemia, and respiratory difficulties, and the prognosis also not good. And childhood form is associated with premature loss of tooth and rickets-like change. And adult form, it's sometimes show the fragile bone fracture. And the last one is the odont form, which is the teeth involvement only. This slide showed a brief explanation of the pathogenesis of HPP. As I told before, HPP is caused by the mutation in the LPL gene and leading to the enzyme activity defect and low LP activity. And then the substrate of LP accumulated, such as PPI, pyrophosphate, and PLP, pyridoxal phosphate, active form of vitamin B6, and phosphoethanolamine, PEA. And then the PPI is an inhibitor of mineralization, so hypophosphatasia showed the hypomineralization or mineralization defect. That's a simple explanation. And to understand the biomineralization events better, the slide is helpful. The biomineralization is the process which is regulated in terms of time and space, and in coordination of many molecules. MV stands for the matrix vesicle. It is a place where the mineralization occurs. Matrix vesicle is secreted from osteoblast. And then matrix vesicle has TNS-LP and the phosphate transporter PIT1 and 2, and another enzyme, NPP1, and the calcium channel or annexin. And then phosphate and calcium is concentrated in matrix vesicle, and the hydroxyapatite crystal is formed in matrix vesicle. Another important factor is PPI, pyrophosphate. Pyrophosphate has a structure like POP, and binds to calcium and inhibit the formation of the hydroxyapatite. TNS-LP dephosphorate pyrophosphate and generate phosphate, an important component of the crystallization. So EPP1 is generated from ATP or ANK transporter from intracellular space. This is the process of biomineralization. And when the TNS-LP activity is impaired, dephosphorylation of pyrophosphate is blocked, and the accumulation of pyrophosphate is occurred. And pyrophosphate inhibit the binding of calcium and phosphate crystal formation. So then biomineralization is lowered, and such appearance in bone is observed in patients with HPP. So there are many subgroups in HPP, and the clinical features are quite different according to the subgroups. I will explain the subgroups one by one and start with perinatal form. In perinatal form, there are two types of perinatal form, as I explained before. One is the lethal form, shown in the left panel. As you can see, the severe mineralization defect in skull or lips or long bones observed, and the lung functions are severely damaged, and the patient died soon after birth. And the second form, non-lethal or benign form of perinatal, is shown in the right panel. As shown in the right panel, there is no mineralization defect, but deformity in long bones like this are observed. However, the prognosis is good, and the patient shown in this slide is now surviving and without no life-threatening complications. So almost 20 years, so the patient become adult. In addition to the case, as I shown in the previous slide, there are two more additional cases of benign type of perinatal form. As you can see, that the findings in X-ray is the same. Deformity of the long bones and no indication of the mineralization defect. And also the prognosis is good. So please note that there are two types of perinatal form of HPP. In concerning non-lethal or perinatal, benign perinatal form, Dr. Michael White's group, the researcher in the HPP field, also recognized the non-lethal form in US. So we think that the non-lethal perinatal form is commonly recognized in US and Japan. According to the severity or poor prognosis of HPP, here is the mortality rate or survival rate. As you can see that the 42% and 31% and 27% is a survival rate at the age of 1 and 1.5 and 4 years of age. So you can say that the very poor prognosis in severe perinatal and infantile HPP. So this is a natural history of HPP reported in 2014. Let me introduce my experience in a patient with severe hypophosphatasia. The patient is a girl aged 1 year. Female length shortness and polyhydramnios were observed at the 28 weeks of gestation. Diagnosis of perinatal HPP was suspected by 3D CT. The patient was delivered by scheduled cesarean section at 37 weeks of gestation. The birth weight was 2,682 grams and height was 42.8 centimeters. The patient was promptly intubated and mechanical ventilation was commenced due to poor respiratory condition. Family history. The parents were consanguineous, healthy, with no family history bone disease, including her sister. And the diagnosis of HPP was confirmed by low serum ALP activity, 2 units per liter, and whole body bone radiogram, which showed remarkably insufficiency of bone mineralization throughout the body. Sequencing analysis of LPL revealed homozygous mutation in exon 12. Consistent with the description, the mutant showed almost no LP activity. So there are several modalities to make diagnosis of HPP in fetus. Ultrasound detection in fetus, in this case, showed that the decompression of the skull, because the pressure test examined the firmness of skull, and the decompression indicates that the softness of skull. And in the right panel, enhancement of echo shadow like this behind femur, indicating that demineralization of femur. So they are suggesting that a mineralization defect in bone. And another modality is 3D CT. Of course, 3D CT is not recommended in all cases because of radiation exposure. But there are some ways to reduce radiation exposure. We sometimes perform the 3D CT to confirm the diagnosis of the skeletal dysplasias. As you can see in these patients, in these panels, there are calcification defect in calf area, like this, and thin limbs without fracture, and cupping in long bones, like this. So these findings suggest HPP. And babygram at birth. So as you can see that hypomineralization in skull, vertebrae, and long bones. And thin limbs, narrow chest, lung hypoplasia, and irregular metaphysis, and or lactic change. So in such cases, we have to do something. And today, it's not the topic of the treatment in HPP, but these cases have poor prognosis, and we have to develop new treatment. And I move to the infantile form. Manifestation of HPP may not be recognized if immediately after birth, as I shown before. Failure to thrive is a key word in the HPP of infantile form. Failure to thrive is a commonly early symptom in infants with HPP. 76% of patients with perinatal or infantile HPP were diagnosed with failure to thrive. So failure to thrive is the first finding in HPP. And the signs of failure to thrive can include poor feeding, inadequate weight gain, irritability, excessive crying. And as a cause of failure to thrive, hypercalcemia may be observed. Hypercalcemia may cause episodes of recurrent vomiting, gastric reflux, nausea, and with gastritis, which can contribute to failure to thrive. So why the hypercalcemia occur in HPP? So as you know that the calcium in extra space or in serum is the main target to regulation. The balance of calcium intake and output contribute to the maintenance of calcium. And the bone plays an important role to maintain the calcium in serum because bone formation and the bone resorption is coupled. But in pathogenic events such as cancer metastasis to bone, the bone resorption goes over the bone formation, and sometimes hypercalcemia occur in cancer metastasis. Like this, in HPP, hypomineralization means that the bone formation is very poor, and then the calcium is overloaded in extra space, and the hypercalcemia may occur. In infantile HPP, present before or 6 months of age with signs of rickets, hypercalcemia, poor feeding, and failure to thrive. And the low calcium milk was given to reduce serum calcium before ERT is available because the calcium excess is the cause of hypercalcemia. Bone is not does not work as a reservoir of calcium. And sometimes we see such kind of radiolucency. We call it a tongue-like radiolucency as typical findings in HPP. And then move to childhood form. Systemic manifestation of childhood or juvenile HPP can include like this. And definition of childhood HPP aged from 6 months to 18 years of age. And as a skeletal manifestation, rickets and the bowing of long bones are important. And the muscle weakness and the joint pain another issue in HPP of childhood. And a short stature sometimes found, and the premature loss of this is also the hallmark of HPP. And another important complication of HPP is craniosynostosis, as shown in the slide. Like this, a typical case of craniosynostosis. So this is a severe case, and is sometimes more pronounced in childhood and resulting in neurologic complications and the need for cranial surgery. So these numbers from natural history of HPP, but my experience is much lower than these numbers. But still, we have to be aware of complication of craniosynostosis in HPP. And odont form. Premature tooth loss with root intact is a hallmark symptom of HPP. So premature means prior to age 5, traumatic loss of deciduous teeth, baby teeth, with the root intact may be an early symptom of HPP. In patients with HPP, a cellular root cementum is deficient, resulting in compromised periodontal attachment. So easy to come out or come off. So because tooth is buried in alveolar bone and attachment is confirmed by cementum, which is the tissue of mineralization. So a kind of mineralization defect in cementum leads to the loss of premature loss of teeth. And in natural cause of the loss of teeth, baby teeth, is the resorption of the root of baby tooth. So these parts come off in natural cause. But in HPP, root is intact is a very important finding. And maybe a traumatic tooth loss may be seen at any age in patient with HPP. So premature loss of baby tooth means age prior to age 5, but even in adult tooth, a traumatic tooth loss may occur like this. Spontaneous tooth loss during tooth brushing, like this, and the radiograph reveals delayed tooth eruption and enlarged pulp chambers and thin denting. So tooth is a target of the HPP finding. So please be careful about the finding of tooth in patient. And then adult form. In textbook, adult form is very mild and very hard to tell, but in these days, adult patients with HPP have some important or serious complications, like pain or fracture or inflammation, and the renal failure or nephrocalcinosis. And the typical one is atypical fracture. So according to the case report, 55-year-old HPP patient misdiagnosis with osteoporosis, and bisphosphonate therapy was given. So bisphosphonate was given with bilateral atypical subtrochanter fracture like this after slightly rotating her trunk while standing at work. So never give a patient with HPP with bisphosphonate. So genetic diagnosis, my experience in Japan. To understand or to clarify genotype-phenotype relationship, Japanese patient with hypophosphatasia, we performed a genetic test in 45 Japanese patients with HPP. They consist of 23 cases of perinatal lethal and 11 cases of perinatal benign, and 6 infantile and 3 childhood and 2 odonto. So more than half perinatal form. And we performed LPL mutation analysis by PCR direct sequencing. And as a result, mutations are frequently detected in LPL gene of Japanese patients, these 2 mutations. C1559 del T were 42%, and the F310L account for the 13% of patients. These mutations were exclusively found in Japanese patients, suggesting founder effect. In addition, to genotype-phenotype relationship, the del T is associated with the severe case, and the FL mutation is associated with benign case, as shown in the slide. Mutations detected in patients with perinatal benign form, in 11 cases, perinatal benign form. And as you can see that the FL mutation associated with these patients. So, and the outcome all alive. FL mutation was associated with perinatal benign form of hypophosphatasia. To understand the enzymatic activity of mutated LP, we constructed expression vector of these wild type and these mutated mutations. And as you can see that the enzymatic activity according to concerning the enzymatic activity, del T mutant lost completely, and the FL mutation showed that the comparable 70% or 60% of that of wild type enzyme. So it explains, especially at least partially, the del T mutation is associated with severe form, and the FL mutation is associated with benign form. So I skip these cases here. Talking about the serum ALP activities in the cohort. Perinatal lethal form, the LP levels 16, and the perinatal benign form 120, and the infantile 85, and childhood 99, almost 100, odonto 136. So there is some association between LP activity and clinical severity. And summary and discussion in this part, two mutations, del T and FL, were common in Japanese HPP. The mutant LP carrying del T completely lost the enzymatic activity, and all of the patients homozygous for this mutation exhibit the perinatal lethal phenotype. On the other hand, FL mutation retained some activity and associated with the perinatal benign form. And mutation analysis will provide useful information on the patient's prognosis and who should be treated. And HPP, extraskeletal manifestation. In addition to the skeletal manifestations like rickets or osteomalacia or premature loss of tooth, there are some complications in extraskeletal tissues like neurologic, respiratory, and gastrointestinal, renal, and muscular involvement, like seizures and respiratory failure, gastritis, and nephrocalcinosis, and hypotonia in muscle. So HPP affects more than just bones. So truly HPP is a metabolic disease affecting almost all kinds of organs. And HPP impacts all organs, so including growth, development, and functionality and daily life. So it leads to the poor quality of life in patients with HPP. HPP diagnosis, very important finding is low LP. So to make a differential diagnosis of HPP, low serum LP is a key finding. But not only HPP, but also other conditions show the low serum LP, which is termed hypophosphatemia. So please note the difference between the hypophosphatasia and the hypophosphatemia, which means that low serum LP. And hypophosphatemia is caused by these conditions, including HPP, Cushing disease, and the other form of skeletal dysplasia like cradle-cranial dysplasia or osteogenesis imperfecta type 2, or zinc or magnesium deficiency. So low LP means low turnover of bone, which is typically associated with the glucocorticoid excess and the malnutrition. So we have to check the serum LP several times to see the persistency of low LP, and the other laboratory tests are necessary to make diagnosis. And please also note that the difference level is different according to the gender and age. So dark blue shows that reference or normal levels of LP. These are numbers. So for example, less than 15 days of 90 to 273 is the normal level. So it means that less than 90 is low, means low LP, or less than 134 means low LP. So please note this pattern. And of course, you know that the adults shows a low level of LP in healthy control than compared to the healthy growing stage. So please use the reference level according to the age and gender. And another problem is the HPP phenotype is various, and which may be overlapped with other common diseases, such as nutritional rickets and osteogenesis imperfecta and hypophosphatemia, hypophosphatemic rickets, and osteoarthritis, osteoporosis, periodontal disease, and osteomalacia. These diseases which should be excluded to make diagnosis of HPP. Since that phenotype in HPP is diverse, it is sometimes difficult to make diagnosis of HPP in some patients. And here is a paper concerning the diagnosis of HPP written by Drs. Bishop, Mans, and me in 2016. So key findings for diagnosis are low LP activity and age and gender adjusted, you have to remember. And the one more clinical findings described in the left panel, like hypomineralization and short stature, hypotonia, premature tooth loss, respiratory insufficiency, renal failure or renal calcinosis, and vitamin B6 responsive seizures. These findings suggest HPP and rule out other low LP causes. We organized the Japanese hyposphagia study group funded by Ministry of Health, Labor, and Welfare, and established the diagnostic criteria of HPP. Main features are hypomineralization or lactic change in bone X-ray and premature loss of teeth. We say that at the age of 4. And low LP activity. And other features include elevated urine phosphoetanolamine, high serum inorganic pyrophosphate, but which is very hard to measure, the hypercalcemia in infancy, and positive family history, and relatively low LP activity of parents. And finally, genetic diagnosis. Mutation in the LP gene is the final approach. So summary, clinical. HPP is a life-threatening, progressive, systemic, lifelong inherited metabolic disorder caused by loss of function mutation in the LPL gene, which encodes TNSLP. Early assessment and diagnosis of HPP are critical. The biochemical hallmark of HPP is low serum LP activity. Presence of clinical manifestations and low age and sex-adjusted LP activity can confirm a diagnosis of HPP. Patients of all age may experience a range of potentially devastating systemic and skeletal consequences, including craniosynostosis, severe hypomineralization, fractures, bone pain, rickets, osteopenia, and respiratory compromise, vitamin B6 responsive seizures, increased intracranial pressure, nephrocalcinosis, and renal complications, and proximal myopathy, muscle pain, missed or delayed motor milestone, immobility requiring wheelchair or other assistive device. At diagnosis, comprehensive clinical assessment and medical history are essential. And the summary, bone metabolism. HPP is associated with hypomineralization. LP is an essential factor for mineralization because hydrolysis of pyrophosphate, an inhibitor of mineralization by LP, leads to release of phosphate. Enhanced bone formation requires a large amount of calcium. If the requirement is not met, hypocalcemia may occur. This is the statement after the treatment. Impaired mineralization associated with hyposphagia or rickets gives characteristic findings in radiographs of long bones in children. ALP or BAP, bone-specific alkaline phosphatase, is a bone formation marker. So thank you for your kind attention. Here is my collaborators. Thank you.